Welcome back, folks. So some of you all were with us this morning for Bradley's first session. And if you're not, I want to introduce Bradley Buchheit from OHSU, who's going to talk us through inductions this afternoon. So everyone, please welcome Bradley.
Awesome. Thanks, everyone. I apologize in advance. My parking kitty expires in 5.5 minutes, so I will have to re-up my parking about 6 minutes from now. So if my alarm goes off, that's what it is for. Okay, we have an hour together this afternoon, and we're really going to dive into best practices around initiating medication for opioid use disorder. So I have nothing to disclose. One thing that I will say is, although we're not talking about any non-FDA approved indications for medication for opioid use disorder, we will be discussing some non-FDA approved induction protocols as far as how, if you were to read the FDA insert about buprenorphine, how they would recommend initiating that medication. So I just want to sort of throw that out there. By the end of our talk today, hopefully you'll be able to describe unique characteristics of fentanyl and how that can contribute to challenges when initiating medications for opioid use disorder, describe different buprenorphine induction techniques and whether or not there's any evidence to support those techniques, describe how to initiate extended release naltrexone, as well as get a better understanding of how someone might initiate methadone if you were to send them to an opioid treatment program. So, as a refresher, the medications that we have that are approved for treatment of opioid use disorder, there are 3 of them: methadone, buprenorphine, and naltrexone. Methadone is a full opioid agonist, which means that when it binds to the mu opioid receptor in your brain, it activates it 100%. When you are under the age of 18, it is difficult to get access to methadone. The only people who are eligible who are under 18 to go to a methadone clinic have to have shown that they have failed 2 prior treatment episodes and they need parent or guardian signed consent in order to continue with treatment. The nice thing about methadone, because it's a full opioid agonist, is it helps with withdrawal and cravings. You have to go to the clinic daily to dose methadone, and it can only be gotten at an opioid treatment program. You can't prescribe it to a pharmacy. Buprenorphine, on the other hand, is a partial opioid agonist, so it activates that receptor probably 30 to 50%. So it still helps with cravings, still helps with withdrawal, but you don't get the adverse safety profile as like a full opioid agonist, so it's a safer medication. It's FDA approved for anyone over the age of 16 or 16. It comes in a film under the tongue. It also comes in a monthly or a weekly injectable formulation. And you used to have an X waiver, and now you no longer need special training to prescribe buprenorphine. All you need is a DEA number. Naltrexone is an opioid antagonist, so when that binds to your mu opioid receptor, it does not allow anything else to bind to that receptor, and it activates it 0%. It's FDA approved in individuals over the age of 18. It helps with cravings only. It's not going to help with your withdrawal symptoms at all because it's not activating that receptor. And it comes in a tablet form or long-acting injectable form. Usually for opioid treatment disorder, we use it in the long-acting injectable form because the oral form of naltrexone has not been shown to be superior than placebo, mostly due to people just not taking it when they don't want to take it. The one scenario where it is probably reasonable to try oral is if someone is having an individual watch them dose, then it has been shown to be somewhat effective. And you don't need any special license or training to prescribe naltrexone. So efficacy of these medications, again, for people who are with us this morning, this is probably a repeat, but they are known to reduce overdose deaths by 60 to 80%. They reduce non-prescribed opioid use, they improve retention and treatment, and they reduce the risk of hepatitis C and HIV transmission. The number needed to treat, is everyone familiar with the number needed to treat and what that means? So you have to give so many prescriptions or treat so many people to have a certain outcome. Number needed to treat to keep someone engaged in care for buprenorphine, anyone know? 2. 2 prescriptions, and one of those people is probably going to come back to see you. There's very few interventions in medicine where we have a number needed to treat of something that low. So keep that in mind. Naltrexone has been shown to be just as effective as buprenorphine and methadone in those above metrics once it's initiated. The difficulty with naltrexone is that it's hard to start, right? You have to be off opioids 7 to 10 days. Not very many people can be off of opioids for 7 to 10 days and feel okay. And so getting that first injection is challenging. It's also important to note that when people are on extended release naltrexone, their risk of overdose after they stop extended release naltrexone is higher than it would have been if they never used extended release naltrexone. So how does that make sense, right? If you imagine someone has something blocking your opioid receptors for 28 days, nothing's going to be able to bind to those receptors. That means your tolerance is going to go down substantially. And then once it's no longer in your system, if you don't get that next injection and you use the same amount of opioids that you had used 28 days prior, that's not going to end well. So that is some of the newer data on extended release naltrexone. I think it works well for some people, but other people it's not a great option. As far as adolescents, really there's a paucity of data, but there is some to show that it reduces non-prescribed opioid use. Sorry, that's my parking kitty alarm. Give me 1 second.
Well, okay, so while he's doing that, I have a question that maybe Bradley doesn't have to answer. But like, if folks are on naltrexone, I feel like a client that I'm working with would be on naltrexone and then they might want to try to use while they're on it, right? That feels like real. And then they are trying higher and higher doses to feel anything, to the point where then like they do start feeling something and then it's too late. Like is that like a real thing, or is it like, okay, no, you're never gonna feel anything, so it's not like, do you get what I'm saying?
Yeah, so you can overcome blockades on receptors, right? Because nothing blocks 100% of all of your mu opioid receptors, but it's really dangerous. And I don't think we have great data to know like what that quantity of opioids is. But in general, it's not something that I see with extended release naltrexone. It is something that I see more with buprenorphine, right? Sometimes people will say, oh, I tried using the same amount of fentanyl that I used to use, and I took my buprenorphine this morning, I didn't feel anything, so I used a little bit more, and then finally I felt a little bit of something. And so we'll talk a little bit about how that can complicate our induction protocols later on. But getting back to other data around efficacy in adolescents and young adults. So really what we know is that it's pretty effective, similarly to adults. I think the bigger issue, which is also an issue in adults, but even a larger issue in adolescents and young adults, is access to MOUD, right? So this was a study out of 2020 that looked at 13 to 22-year-olds who presented with a non-fatal overdose, and only 2% of all of the people who came in with an overdose were started on MOUD. 2%. So I think part of it is just starting to prescribe, and then that will be half of the battle. The other thing that's important to note in this study looking at Medicaid and commercial populations is that younger patients are less likely to receive MOUD. As far as recommendations, again, the American Academy of Pediatrics and the American Society of Addiction Medicine both recommend using medications for opioid use disorder, especially in individuals who have a severe opioid use disorder. Okay, so let's talk about fentanyl and fentanyl analogs. So what is fentanyl? Fentanyl was first synthesized in the 1960s as a pain med. It's currently Schedule II. We have seen an uptick in fentanyl overdoses since 2010. And now about 70% of all of our drug overdoses, at least those in 2021, were all related to fentanyl and other synthetic opioids, not including methadone. And if you look at specific Oregon data, we have seen a doubling in overdose deaths due to fentanyl between 2020 and 2021, and I suspect 2022 data is not going to be great either. As far as adolescents specifically, this is an article that was in JAMA in 2022. You can see the graph on the left there. The portion of the graph that's sort of shooting through the ceiling is fentanyl overdose deaths. And this is in 12 to 17-year-olds. So we used to not see fentanyl overdose deaths in this age group, and now we're starting to see sort of a similar trend as we're seeing in adults, and so it's becoming more and more of a problem. And so why fentanyl? Like, why is it in our drug supply? Nora Volkow, the director of NIDA, she has a commentary that talks a little bit about it. Some of the reasons are it's probably less difficult to traffic than heroin. Since it's so much more potent, you need to traffic smaller amounts to sort of get the same effect. And so, you know, instead of 10 kilos of heroin, maybe a 50th of a kilo would be the equivalent, and that's much easier to hide and to move. And so it is highly profitable for people, and it's relatively easy to manufacture. As far as fentanyl analogs, we don't really know what's in our street fentanyl. I say fentanyl, and when I use the term fentanyl, it's fentanyl and fentanyl analogs, but that's like a huge mouthful. So I'll just say fentanyl, but we don't know, right? No one's out there taking samples from people who are using drugs and monitoring like what's actually in the drug supply, except for Outside In. I think they are doing a little bit of that, which is amazing, but that's not really data that's easily accessible by most people. And so we don't really know what type of fentanyl analogs are in the drug supply. We don't know their pharmacologic properties. We don't know how potent they are. And so it makes treating someone who's using fentanyl and fentanyl analogs challenging. If you look at fentanyl, right, it, like other opioids, binds to that mu opioid receptor. It usually has a high affinity. It usually is super potent. And how potent, you may ask? 80 to 100 times more potent than morphine and 30 to 50 times more potent than heroin. So it's substantially more potent than what we're sort of used to seeing. And so when you think about buprenorphine and methadone and extended-release naltrexone, all of those studies for FDA approval were done in an era where we were seeing only fentanyl use, right? So it highlights the need that we may need to change some of our treatment practices in order to sort of stay up to date with what's actually happening in the drug supply. This is an interesting article looking at how fentanyl, so right, we think of who uses fentanyl in like an emergency room setting, and like, it's great, right? Fast on, fast off. So we actually used it a ton in pediatrics, intranasal fentanyl, so you don't have to poke that poor child, just have them sort of snort a little bit of fentanyl, right? You can relocate their shoulder within 30 minutes, they're almost back to their normal self, right? And so everyone has always thought of fentanyl as being this fast on, fast off medication. What we're finding, though, is all the pharmacology studies that we looked at fentanyl, they were getting medical doses of fentanyl in an isolated situation, right? They weren't having repeated high-dose fentanyl exposures. And so what we're seeing, actually, so this study was looking at 50 people who were admitted to a residential treatment program, and they did urine toxicology every day, and they looked for fentanyl and the metabolite of fentanyl, which is norfentanyl, and they found that on average, urines took 7.3 days to no longer be fentanyl positive in individuals who were using high quantities of fentanyl, right? And it took 13.3 days on average for norfentanyl to get out of their urine. There was one person who was in the study who left the 28-day treatment program and still had positive norfentanyl values in their urine. So it is sticking around much longer than we initially thought, which again can complicate our induction protocols when we're talking about buprenorphine and or naltrexone. So, as far as recommendations, right, we know that MOUD is recommended for treatment of opioid use disorder, including fentanyl use disorder. So buprenorphine, extended-release naltrexone, methadone. But what I think we're seeing is that we're seeing increased precipitated withdrawal with individuals who are using fentanyl, more intense cravings for people who are using fentanyl, so we may need higher doses of buprenorphine, and increased withdrawal symptoms. And so how do we get people onto buprenorphine in ways that they're going to want to stay on buprenorphine? And so that's really looking into some of these novel techniques for initiating bup. So like I said, buprenorphine, partial mu opioid agonist, it's metabolized by the liver. It's available in both sublingual and long-acting injectable formulations. The half-life is pretty long, 37 hours for buprenorphine, and it takes about 30 to 60 minutes for peak effect. So when someone puts a tablet under their tongue, you get maximum effect within 30 to 60 minutes, which makes up titration a little bit faster than something like methadone per se. The issue with buprenorphine, right, is historically what we've done is you have to have someone who's in acute withdrawal before you initiate that first dose of bupe. And does anyone know, is it the buprenorphine that causes that? Is it the naloxone that's in Suboxone that causes that precipitated withdrawal? It's the bupe, yes. So common misconception, which is probably because of healthcare providers. When we first started teaching people about buprenorphine naloxone, the PCSS training that you used to have to do to get your waiver training, people would say that it was the naloxone that was added to the Suboxone that caused people to have precipitated withdrawal. So I meet a number of patients who will say, well, I want Subutex only because I'm not going to go into precipitated withdrawal. And so I usually explain to them sort of why people go into precipitated withdrawal, that buprenorphine will kick anything that's on that receptor off, and it will activate, if it was bound by a full agonist opioid, it will go from 100% activation down to 30 to 50% activation, which will make you feel really sick, regardless of if the naloxone is added in there. So it's definitely the buprenorphine that's causing it, and it results in sort of that rapid move from full agonist to partial agonist. And so if you think about the conventional induction, is if someone had no opioids on the receptors and they're in withdrawal, so zero activation, and you give them something that's activating those receptors by 30 to 50%, they feel better, right? So types of induction, so we'll talk about conventional induction and we'll talk about novel induction protocols. Conventional induction, really in the fentanyl era, like maybe we should be using a higher cows before we give their first dose. Who knows? It used to be about 10 where we would recommend giving that first dose. Now maybe should it be 16, should it be 18? No one really knows. We used to give as needed adjunct medications when we're doing conventional induction. Should those be scheduled now? We'll see. And then as far as in novel induction protocols, there's low dose inductions, also known as micro inductions, high dose inductions or macro inductions, and the quick start method, which is sort of a form of macro induction, has the least amount of evidence. So thinking about our conventional buprenorphine inductions, right? So it used to be last opioid use 12 hours ago, hit yourself with 2 to 4 milligrams of buprenorphine. Every 1 to 2 hours after that, you would take another 2 to 4 milligrams of buprenorphine until you started feeling better, up to 8 milligrams on day 1, 16 milligrams on day 2. Bada bing, bada boom, you're on bupe, let's go, right? How many people still use conventional inductions in practice? Or have you ever used a conventional induction? Right. How well does this work now?
It does not.
Exactly. I think the only time that I've had this work is if someone wakes up in the ICU and they've been getting IV hydromorphone for 7 to 10 days, and we know that they have not been using a longer acting opioid, and then I can do a conventional induction like this. That's really the only time. Or in corrections, yeah, when they're sort of, they don't have any opioids in their system. So this is what we used to do. And we would just give them some supportive medications, clonidine, ondansetron, tizanidine, loperamide, hydroxyzine to help with some of their additional withdrawal symptoms that may not have been managed on that day 1 or day 2. Advantages of this, right? It only took 1 to 2 days, maybe. People were able to stop their opioids immediately, and it has the most data behind it. Disadvantages, well, we're seeing it. Precipitated withdrawal, people not wanting to be on bupe after experiencing that. You have to go into withdrawal to do an induction like this, and some people are like, absolutely not, I'm not gonna feel that way. And then you may not ever be able to get to a high enough dose fast enough in the era of fentanyl. So, may not be the best way moving forward. Low-dose inductions, also known as microinductions, the theory behind them is as you continue to use your full agonist opioids, you slowly, over a period of days, introduce more and more buprenorphine. So more and more of those mu opioid receptors are slowly being bound by buprenorphine, which has a very long half-life. And so over 7 to 8 days, you may have some mild withdrawal symptoms, but in general, people don't even recognize that they're having sort of a crossed taper from their full agonist opioids onto buprenorphine. There are a million different protocols as far as how this works, and there really is very limited evidence, if any, to support doing this. Here's what one of these protocols looks like in real life. So the top one is a protocol that we use in the Harm Reduction and Bridges to Care Clinic at OHSU. It's an 8-day protocol, and so you start with a baby dose of buprenorphine. When we used to use 2 to 4 milligrams for our first dose, we now start using 0.5 milligrams for our first dose on day 1. On day 2, 0.5 milligrams twice a day, right? And you slowly ramp up that dose until you get to about 12 milligrams, and then you hope that most of those opioid receptors are bound by buprenorphine, and so the next day you would just sort of rapidly titrate up your bup, similarly to how you would have done if you were doing a conventional induction. The difference here is we would usually go up to 24 milligrams on that day if they needed it. Another rapid dose protocol, so it's a rapid low dose protocol. This one we also use in Harbor, and for some people they're really successful at this. It's only 4 days. And so you go up a little bit more quickly, but it's still small, frequent dosing instead of the larger, less frequent dosing. And again, the theory is trying to bind more of those receptors slowly so that it doesn't push people over into precipitated withdrawal. There's also a Bernese method that you may have heard about where you put a buprenorphine patch for the first day. The reason I didn't really talk about that is buprenorphine patches are FDA approved for chronic pain, and so getting them covered by insurance is almost impossible, especially if you're using it for OUD. So in a hospital setting where you may have access to the buprenorphine patch and it's not something you need to get approved by insurance, it's a great option. In the outpatient world, I've never seen an insurance company approve Butrans patch for this specific use. So what's the evidence behind this? There's a systematic review from Mo et al. In 2021. There were 19 cases they looked at, so a total of 57 people, so super small. There are 26 different regimens that they used, right? So talk about like heterogeneity, right? So 54% of patients were using non-prescribed opioids. Some people were using prescribed opioids when they did the transition. I think the important thing to note here is that only 5% of people had precipitated withdrawal. And they were unable to comment on the effectiveness or the safety of this induction protocol due to lack of studies. But what they did say here is that there's a paucity of high quality data. We need to do more. Applications of these types of methods may be concerning because we don't have great data to support them. However, there is this ongoing opioid crisis, and it's been more and more challenging to initiate people on these medications. And so clinically, I think people are trying some of these things. Yeah.
So we're primarily using low dose. I think we're looking at the like low to high or rapid low. We just haven't yet. I think one of the things we're seeing most is like it's taking more than one shot. Like it's taking 2 to 3 times. Mm-hmm. And I wonder if it's like because they still have to go and get the fentanyl. They still have to go and like engage in that behavior and put themselves in situations. I don't know if that, I mean, I'm sure that's part of it. But yeah, I wonder if that's a similar thing that other people are experiencing.
Yes, we are definitely seeing that when we do low-dose inductions. It's pretty rare that the first time works, but some people it does. The other thing that I think is really difficult about low-dose inductions is it's a lot of instructions, right? You're changing the dose daily, the frequency daily, the type of pill every 3 days because you go from the 2 milligrams to the 8 milligrams. You have to check in with them regularly. Access right now at most clinics is horrific, and so like those daily check-ins or every 3 days is like really, really challenging to do, right? And like it depends on the social supports that they have. A lot of the patients that I see don't have great social supports, and so their meds are getting stolen or they're misplaced and they don't have some place to cut it, or they don't have scissors to cut the film so they can have the small enough pieces to do low-dose inductions. But we sort of try talking to people. I think having a visual aid if you're doing in-person visits is key. Talking about supportive medications is helpful. So like, are you really anxious about this? Let's get you some hydroxyzine and maybe we can schedule it for the first few days that you're doing it instead of having it as needed. I usually tell people to take their AM buprenorphine dose before they start using full agonists for that day because it seems to be a little bit better tolerated. But again, no data to support that. That's all anecdotal. And then I often will counsel people when we start this process is don't escalate your full agonist use to try to continue to feel euphoric as you're escalating your buprenorphine use, because then you get in a situation where you're on 24 milligrams of bup and you're now using substantially more fentanyl. And when you try to stop it, you have withdrawals, but you're already on a max dose of buprenorphine. So those are some of the things that I will often counsel people on. Regular check-ins I think are helpful. And then if it's not working, I tell people if you take a dose and you're feeling terrible, repeat the day before, call us, and then we can check in about next steps. And then make sure we also talk about naloxone and overdose prevention. So this is a visual aid that Hooper, medically managed withdrawal, uses as far as like their protocol. So you can see that they sort of like did some diagrams of like cutting the films into quarters and how you would take it, right? The other thing that I'll tell people is these are meant to be dissolved under your tongue. They do not break like normal pills. They crumble. And so if you're gonna be trying to break them into pieces, doing it in a Ziploc baggie so it doesn't fly all over the place. Same with the films. So the film doesn't fly in the ground and you're looking for a quarter of a tiny little film on the ground. Really difficult to do. So I recommend doing that within a Ziploc baggie so you can just sort of eyeball the amount of crumbles and say it's about a quarter, right? So advantages of this, patients don't need to be in withdrawal, and they often don't experience withdrawal during this if they can complete it. It tends to avoid precipitated withdrawal unless they accidentally confuse the 2 and the 8 milligram films. And you're taking a quarter of the 8, which is 2 milligrams, instead of a quarter of the 2, which is 0.5. And it allows, like if you were doing this transition for someone who's on chronic pain, opioids for chronic pain, you can continue your full agonist opioids for pain while you're transitioning them to buprenorphine. So we do this a lot in the hospital setting, right? Someone comes in, they have an acute injury, they're on opioids for pain management, and they also have an opioid use disorder, so we transition them to bup in the hospital, and they do very well. Disadvantages, right? It takes time. They're complex instructions. Some patients will have some withdrawal symptoms. I think another disadvantage is you have to keep using full agonist opioids during this whole process, which means you're still at risk for overdose, still at risk for infectious complications if you're injecting, right? There is very limited, if any, evidence to support doing this. There's many protocols. Which one's the best? We have no idea. And if you're doing the Bernese method with the transdermal buprenorphine, it's not covered usually. So let's talk about high-dose macro inductions. So the theory behind this is, what do people do when they have precipitated? Have you ever done an in-office induction and precipitated withdrawal in anyone? Yeah? What did you do? You gave them more bup, right? And so in theory, right, what we were trying to do is if we can displace or like partially agonize as many of our mu opioid receptors as possible, maybe they'll feel better. And so the theory of high-dose inductions is instead of waiting until they're in precipitated withdrawal, why don't we just hit them with a max dose of buprenorphine, occupy all their receptors, and then maybe they'll feel better, right? So this is happening in emergency rooms usually. I've not seen a ton of data to support this in the outpatient setting, although California Bridge does talk about an outpatient protocol for this, which is on the next slide. I know this is super tiny, so I apologize. And as I was making this slide, I was like, this is going against all of my sort of presenting like skills, but I couldn't make the slides any bigger, so this is sort of where we're stuck at. But you can go to bridgetotreatment.org and see these nice PDFs. One on the left is the outpatient protocol. The one on the right is their inpatient ED protocol. What they do is they say, wait until you have a COWS score of 8 to 12, or you're having 2 severe withdrawal symptoms, and then you take 8 to 16 milligrams of buprenorphine. If you're feeling sick after that, within an hour you take another 8 to 16 milligrams of buprenorphine, and then sleep it off. So again, I've not used this in the outpatient setting. I know our emergency department loves this because if you think of the average emergency room stay, it's about 6 hours, right? Not long enough to do a microinduction, not long enough to do a conventional induction. And so this way is, a way to get people on buprenorphine in a timely manner. But again, very little evidence. There was one ED study that looked at 579 cases. The average age was 36, so again, doesn't really apply to adolescents and young adults. And what they did in this protocol was they gave someone 4 to 8 milligrams once their COWS was 8, and then depending on how they looked after that, they gave them anywhere from 4 to 24 milligrams of additional buprenorphine, all as a single dose. They had 0.8% of precipitated withdrawal, so not very many. They had no respiratory depression or sedation related to buprenorphine, which is one of the things that I was worried about when I heard this protocol. And there's absolutely zero evidence in literature that I could find on adolescents and young adults with this protocol. So advantages, fast. Theoretically, there's less risk of precipitated withdrawal, although I've never tried it. Beneficial in situations where someone may have limited exposure to the healthcare system, right? Like an ED. And the other situation where this might be helpful would be post-overdose, right? Imagine someone on the ground, not breathing, you Narcan them, they wake up, they're feeling terrible, you hit them with buprenorphine. There's been some case studies to show that that is actually effective and gets to our next induction protocol that we'll talk about. And you don't need to continue full agonist when you're doing this, right? The whole theory is that you're stopping the full agonist. Disadvantages, some patients may still have withdrawal. There's limited evidence on efficacy or safety, and all I've really seen is that it's been studied, at least the evidence that we have is all in an ED or hospital setting, so not in an outpatient setting. So the quick start method is a version of a macro induction. The difference with quick start, so quick start was developed by Boulder Care. I don't know if people know who Boulder Care is. Telemedicine buprenorphine treatment provider. So quick start is you pre-medicate your patient with clonidine, 0.2 milligrams of clonidine, 600 milligrams of gabapentin, and 8 milligrams of Zofran. Have them set an alarm for 60 minutes on their phone, and then prepare their intranasal Narcan as well as their 24 milligrams of sublingual buprenorphine. When their alarm goes off, they hit themselves with 4 milligrams of intranasal Narcan. Immediately put 3 tablets of 8 milligrams, so 24 milligrams total of buprenorphine under the tongue. And have about a 60 to 90 minute moderate to severe withdrawal syndrome, at which point they feel better after the fact. There's limited data to support this protocol. It is not recommended to do this in people who are pregnant. There's been no evidence to support doing this in anyone under the age of 18, or anyone who has a comorbid psychiatric or medical condition. So, very few people that fit those criteria, at least that I'm seeing in my addiction medicine practices. Questions about bup inductions? I know that was a whirlwind.
We had one person do quick start on her own. We had a whole plan. She was going to be on a video with us, have her boyfriend, but that she just did it. And I mean, she was successful, but it's both super cool and terrifying.
Yeah. I had a patient tell me that it was the worst and the best experience of their life. And the reason I asked her, like, why the best experience, and she told me, because I'm houseless and I don't always have access to a toilet or a safe place to sleep. It allowed me to know exactly when I was going to be in withdrawal, and I knew it was only going to last for 60 to 90 minutes. And so, like, that gave me the power, which was, like, really liberating. Yeah.
So I feel like in the hospital, things have gone beautifully with microinductions, and in the outpatient setting, it's been really hit or miss in my experience, and that ranges from, like, just ordering it is super complicated. Like, there's the patient instructions, there's the ordering it, there's the pharmacy who calls 3 times with questions. Like, I just haven't figured out the outpatient pharmacy prescribing. It's just a disaster, so I would appreciate guidance on that.
Yeah, so at OHSU, we're working on an order set within Epic, so you can just clickety click, 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 and it all just will shoot over to the pharmacy. I will say that 2 years ago, I would always get called from the pharmacy when I was doing a low-dose induction. Now, I rarely ever get called from the pharmacy. I think most, at least in the metro area pharmacies, they recognize that this is what we're doing. When I'm prescribing to Medford or Grants Pass, I usually always will call immediately after I send the prescription and just say, FYI, this probably sounds crazy, but this is what I'm doing. Can you please dispense both the 2 milligram and the 8 milligram films at the same time, even though one is for, like, days 1 through 5 and the other one's days 6 through 8, because I don't want the person to have to go back twice to get the meds. And also, do you have questions for me? And then I think as far as patient instructions, if they have a family member or a loved one who's willing to like join in on the visit or the virtual visit, I found that increases success substantially because someone is like monitoring like what day you're on and then crossing it off. But outside of that, it is really difficult. So Yale did a study where they actually vacuum packed buprenorphine in the little, so like it was just like day 1, dose 1. Day 2, dose 2, right? And so it's like AM, afternoon, PM doses. The issue, at least when I looked at doing this at OHSU, is that most pharmacies will not break a bup tab into quarters because they're only meant to be broken in halves because you can only guarantee accuracy with dividing it in halves, right? So they said if I quarter it, it could be 0.3 milligrams or it could be 0.7 milligrams, and we can't know for sure, so we're not going to cut it. My response was, I don't really care if it's 0.3 or 0.6, as long as it's not 1, right? Didn't really go great with the pharmacist when I responded that way. But I think that if you can get a specialty pharmacy to do that, that would be the easiest way, in my opinion, because then it's just like pop open the bup dose that you need and take it.
We will send, like, it's a bit of annoying because I do have to go to the pharmacy twice, but if we do like day 1 through 5 and then we do 10 day, I'm trying to move out of that because it's long, but and like, yeah, I just ended up making a work because we just haven't gotten around to the smart set yet, you know. So I just have a Word doc that says like, that's exactly how I know most of the pharmacies, so email me. I'm happy to share that. And one of the things I'll upload onto, I want to call it Bandcamp every time, but Basecamp, geez Louise. Bandcamp. We have like a beautiful, like lengthy walkthrough, but the best part is just the grid, like day 1 this, day 2 that. And I chart it, send it to them, and also try to give it to them in person, because yeah, like it is lengthy. But yeah, about usually half like works better with the pharmacies. And I think they like 1/2 versus 0.5, or is it they like 0.5 better than 1/2? I can't remember. 1/2. Yeah.
I think you had a question too, right? Sorry to point at you.
Yeah, and maybe I missed it, but so what method are you finding most helpful when fentanyl, in the context of fentanyl these days?
Yeah, so our approach really is a shared decision making with the patient. So we present all options. So actually, I usually present conventional versus low dose, 8-day or a low dose rapid. And things that I'll ask people is like, do you have access to fentanyl or heroin, right? So they may be coming to you because they no longer have access to opioids. And so low dose induction is not going to be ideal in that situation, because the whole preface of low dose inducing someone onto bup is that they continue to use some full agonist. And so in those situations, I may refer them either to detox or have them wait 3 to 5 days if they can, and give them tons of supportive meds, and then do a conventional induction. And then, we aren't using Quick Start a ton because I think that it could be problematic. And also, I don't know if it's that much different than macro dosing. But we are also not doing a ton of macro dosing in the outpatient world. So I think it's really either low dose induction, rapid low dose induction, or conventional. And I wish I knew which one was better, but there's just like no evidence.
You guys use the high-low, right?
Yeah, I think it's a little bit different, but I think it's sort of like the rapid low dose, but a little quicker. Maybe is what we're using at the county mostly. I mean, we do we kind of do the options, give the patient the options, and they kind of decide what's going to work. Yeah, but I think it's kind of like we start with kind of like a low dose the first day or 2, and then kind of jump up to a higher dose sort of thing.
I think that's what Fora does as well. I think they do like 1 milligram on day 1 and then 1 milligram TID, and then they hit them with 12 the next day. Yeah, and then they also give adjunctive medications. And since they're in an inpatient setting, they have a lot of other options as far as adjunctive meds that I wouldn't feel comfortable prescribing in an outpatient setting, like benzos. Other questions about bup? Yeah.
If it comes to detox, what are the detox options for youth?
I don't think that there are any in Oregon.
I know that there was one in Lane County that recently opened, but I don't know anything about how anyone gets in. And that once I know anything about that, I'll be happy to share that. But I'm assuming that it's very much like a pilot trying to seek the waters of like, hey, like Oregon, we can do this. So
There was one in Vancouver, but it closed daybreak. I think they closed the one that was in Vancouver. I don't know if they closed the other one.
there are other facilities further north. But
Yeah, so currently only 18 plus. So Hooper, Fora, and Recovery Works Northwest just opened a new place in the metro area. Outside of the metro area, I think that there's 2 detoxes in Eugene and maybe one in Medford, but I don't know for sure.
There's one in Otis called Powerhouse, and then Vancouver has Lifeline.
Yeah.
I don't know.
Yeah.
I don't know if we talked. Oh, I'm sorry. I don't know if we talked about this, but it sounds like hospitals are also not super on board with inducting youth. Maybe some are.
So at OHSU we do. So we
Cool.
consult,
That's
our
great.
addiction consult
Duh.
service will go over to Dornbecker and see patients. I don't know if they admit people just for that, but if they're there for something else and they're interested, then we do have an adult consult service that will see them.
Kim, I think you were saying Providence won't, though, right? Okay.
We're going around with CAFU.
I just wanted to clarify. So, when do you stop the full agonist? Is it always when you've hit like what dosage of bup?
Usually 12 milligrams. And so if it's like 4 milligrams 3 times a day, that would be your last day of full agonist use. And then the next day, you would take 12 milligrams all at once, and then every hour, take an additional 4 milligrams as needed, up to 24 milligrams total.
I feel like I was in a training yesterday mentioning particularly with folks who are on fentanyl needing 32 milligrams for their consistent bup dose.
Yeah.
Any feedback?
Yes, we are definitely seeing, so there is some evidence to support increased engagement in doses higher than 24 milligrams. None of it, to my knowledge, is in adolescents and young adults. It's all in adults. But there is a push to ensure coverage of doses up to 32 milligrams. Our current protocol, at least in Harbor Clinic, where we do like low barrier bup inductions, is that we will do a trial of 32 milligrams specifically in the first 1 to 2 weeks post discontinuation of opioids in that like post-acute withdrawal syndrome. And then the hope would be eventually to taper someone back to a 24 milligram dose. But there are definitely scenarios where I think people do better at 32. Again, that is an off-label dose for buprenorphine from an FDA perspective. But I have seen some benefit in select cases. Good question. Okay, extended release naltrexone. So as a reminder, naltrexone is an mu opioid receptor antagonist. It's also metabolized by the liver. It has a very high affinity to that receptor, which is why it works well, right? So when it's bound to that, nothing else will kick it off usually. It's available in oral and extended release formulation, although we don't really use the oral formulation for treating opioid use disorder, more so for alcohol use disorder. Half-life is 5 to 10 days for the injectable formulation. And as far as initiating it, you really have to be opioid-free for 7 to 10 days. If you're using methadone or MS-Contin, extended release morphine, then you probably want to even wait longer, up to 14 days before you initiate naltrexone. When you're initiating extended release naltrexone, it's really recommended that you get LFTs to initiate it, mostly because once you give someone the injection, you can't really take it away unless you surgically remove it. And so making sure that those transaminases aren't greater than 3 times the upper limit of normal and that they have good synthetic function. Also, use caution in doing an intramuscular injection in someone who has thrombocytopenia or who is on anticoagulation because it can leave quite a large blood clot. One thing that you can do to test whether or not someone has used opioids is do a urine tox. Again, an opiate urine toxicology will not pop positive for fentanyl, so keep that in your mind. And then kratom also will not pop up on a urine toxicology exam, so ask people about kratom or tramadol because both of those activate the mu-opioid receptor as well. And we had a case in Boston 2 years ago where they gave someone extended release naltrexone who was using kratom that they forgot to ask about, and they felt terrible for about 3 to 5 days because they were in precipitated withdrawal. And then if you're worried about someone either like having opioids in their system and you just can't find them, you can always do an oral naltrexone challenge where you give someone 25 milligrams of oral naltrexone. Assuming you do a COWS before that and their COWS is 4 or less, you give them the 25 milligrams of naltrexone, repeat a COWS 90 minutes after. As long as their COWS doesn't go above 6, it's considered a pass, and that you can give the extended release injection. Just know that if they do have opioids in their system and you give them 25 milligrams, they're gonna feel very bad and probably throw up all over you or the exam room. And ideally, extended release naltrexone is great when people are coming out of a long period of abstinence, right? So incarceration, residential treatment, detox maybe, unless they were given opioids to detox. Questions about extended release naltrexone? Okay. So what about methadone? So the first thing I just want to highlight is we cannot prescribe methadone for opioid use disorder in an outpatient setting at an outpatient pharmacy, right? The only place that someone can get methadone for treatment of opioid use disorder is at an opioid treatment program where they dispense methadone. They don't prescribe methadone. Methadone, like we talked about, is a mu-opioid receptor agonist. It also is metabolized by the liver. It can cause QT prolongation, and there are a number of drug-drug interactions with methadone. So if you have someone who's on heart therapy for HIV, or taking a lot of Zofran or antipsychotics, just keep that in mind when they're initiating methadone because it can sort of prolong QT. Rifampin is also something that can actually reduce, so rifampin increases the CYP450 metabolization of medications, and so you can actually see 50% or more reductions in serum concentrations of methadone when people are on rifampin. And so when someone comes into the hospital and they're having like osteo and they need like 16 weeks of rifampin, it can make dosing methadone very, very, very challenging because they start having withdrawal at a stable dose because the liver is now metabolizing it much more rapidly. It has a super long half-life. For adults, it's 8 to 59 hours. And for children and adolescents, it was anywhere from like 3 to like 90 some hours. So 19.2 plus or minus 13.6 hours is what Up to Date said. But as you can see here, the ranges are huge. And I think it highlights that every person is going to respond to methadone a little bit differently. So like I said, only at an OTP. There are regulations as far as how rapidly someone can go up on methadone when you're at an OTP. Usually the first day you get 30 milligrams as your first dose. If you're willing to stay at the clinic and be observed in 2 to 3 hours, they may give you an additional 10 milligrams, but they will not exceed 40 milligrams on the first day that you're there. And then the following day, you would get whatever dose you got the day before. And you usually stay at a dose for 3 to 5 days, and then they increase your dose 5 to 10 milligrams per week, which can be a problem, right? Who knows what the average dose of methadone, or at least in the literature, back when it was just heroin, what the average dose of methadone we were sort of striving for. 80? Yeah, 80 to 120. And so if you calculate that out, like 5 to 10 milligrams a week, and you can only start at 40 milligrams the first day, that means 4 to 8 weeks before you get to a therapeutic dose. So that's 4 to 8 weeks where you're probably at increased risk for overdose. Actually, no, the evidence has shown that you are at an increased risk of overdose because you're not really managing your cravings and withdrawal well enough, so then you're often still using full agonist opioids that you're getting off the street, and so that combination can lead to bad outcomes. But because of its long half-life, if you up-titrate it too aggressively, then what you can get is like stacking of the doses, and then people can be fine for day 1, 2, 3, but then maybe day 4, 5, and 6, they start getting super sleepy because that's when they reach their new steady state. And then I put the exception, which I already talked about up here, for individuals who are under the age of 18 and when they can dose at an OTP. And then don't forget naloxone. Naloxone. Questions?
Have you 2 failed attempts before?
Yes.
Of withdrawal management and specifically, like a detox, not?
It could be detox or a treatment attempt. Yeah.
Just full of questions. Do you have any thoughts, or have you guys looked at Sublocade? So like instead of doing, well, I guess you have to do an induction on sublingual first before you can do the injection.
Yeah. So there's a case report, oh God, where is it out of? I think it's Connecticut, where they had 2 or 3 adolescents who they gave like a 4 to 8 milligram dose of sublingual bupe. They tolerated it fine, and so they hit him with Sublocade. Again, 3-person case series, super small numbers, but there have been some literature to at least say it's feasible.
Was it the 100 milligram Sublocade?
I don't remember if it was the 100 or the 300. That is a great question.
Question, but it's kind of going back to bupe a little.
Yeah, that's totally fine.
So what about with buprenorphine and metabolizing it differently? Like you kind of talked about methadone, people metabolize it differently, and sometimes still do like a peak and trough and do split dosing. What do you have to say about that with Suboxone or buprenorphine? Because I kind of see some patients saying it wears off, and so sometimes they're splitting it up through the day, which is helpful if they're also addressing pain. But can you talk about that?
Yeah, so to my knowledge, there's not any evidence to support like when to split dosing. So I think it's really just clinical judgment at that point. And so my general approach is once a day dosing is great because you only have to remember something once a day. If you feel like someone is having withdrawal like before that morning dose, and you could trial sort of split dosing, where if they were on 16, instead of 16 in the morning, you could do 8 in the morning and 8 in the afternoon or in the evening. I think that's reasonable, and just see how they do. I think if it gets more frequent than like 4 times a day dosing, I get a little worried that they're using buprenorphine as like a non-constructive coping mechanism for any anxiety that may happen throughout the day. And so they're reinforcing similar behaviors to when they were using full agonist opioids from the street. And so I worry about dosing that's more frequent. So I have some people who I cut my film into 16 pieces, and then whenever I'm having anxiety throughout the day, I pop 1 or 2, and I'm like, let's maybe focus on like a stable dose once or twice a day, because I think it's really going to help you in sort of like moving forward in your recovery. Let's get you connected with our peer recovery mentor. Let's talk about it a little bit more. But yeah, I don't think there's not quite as good of information about like different metabolizers of buprenorphine. And to be honest, there's far fewer med-med interactions with buprenorphine. And so one thing I have heard is certain manufacturers of generic buprenorphine. I've had patients who say when they switched from one manufacturer to another, they didn't feel the same after they took it. I don't really know what to make of that because I suspect that someone is monitoring what's actually in those pills that we're getting from the pharmacy. And so usually I just say, okay, well, if that's how you feel, we can try to find that medication. However, I'm not a pharmacist and I'm not the one who's ordering these meds that are often back ordered. And so it's sort of like take what we can get at the time that we can get it. But I have heard that.
Okay, yeah, we have kind of the same experience then at the county. And then I guess also for pain, how would you, we also prescribe it for pain sometimes. And so I think patients are splitting it up to even 4 times a day for pain because it's helpful for, is it 2 to 4 hours, something like that?
Yeah, it's usually good for, so if you look at the FDA-approved buprenorphine formulations for pain, it's the Butrans patch, Belbuca, and I think there might be one other one, but I'm blanking on it. They're usually, so the Butrans patch is sort of like a 24/7 thing, and it's good for 1 week. You just put it on, leave it there for a week, and then take it off and replace it. So you're sort of getting small doses, like thousands of times less than what you would prescribe for opioid use disorder. And then the Belbuca is every 12 hours that they dose it. If I have a patient who has an opioid use disorder and chronic pain, then I usually recommend TID or QID dosing, unless they say it's not as helpful. Yeah. Brixadi is the new long-acting injectable medication that actually just hit the market on Monday, the 25th, I think. And so it comes in a number of different doses, both in a weekly and a monthly formulation. And unlike the other long-acting injectable Sublocade, where everyone gets 300, and then you drop to 100, there are actually charts to convert the sublingual dose to either the weekly or the monthly dose. And there are also instructions on how to induce people via the injectable only, the weekly, I think. Again, I've not seen the prescribing insert to know for sure, but that is my general understanding. Yeah, I think it will take.
Cassie, do you want to speak on that? I'm wondering.
So in my conversations with payers in Oregon, they said that before they even assess whether or not they're going to cover something, it has to be on the market for 90 days.
I think I could be wrong, but Cassie can help me out here. But CareOregon is like prepared to cover it, but we aren't super sure of like the availability. That like if a prescriber is saying, yes, this is going to work for my patient and this is what we're going to do, yes, we will cover it and we're ready for that, but we don't really know how easily you're going to get it right now.
More information forthcoming.
Yes.
More information will be coming,
Yeah.
but yes, we are like, we're ready. We love when clients and providers have options.
I wonder if it'll be subject to similar like REMS expectation, or not expectations, but she knows more about it than I do. But just, yeah, I wonder how like complicated that will be.
I suspect it will also be part of REMS. Cool.
Thank you.
Thanks, everyone. Yeah.
Thank you. Okay, just 2 housekeeping things before, I can't go back now, before you all leave. Of course, we still have 2 more days in the learning series left. So if you are not registered for those, please do so. There is a wait list, but we are opening up availability every day. So just know that that's not going to be a barrier. This is one way to get to your CEU evaluation for today. You also all should already have an email that also has the link in it as well. So those are your two options. I think that's it for today. So thank you all very much. We'll see you in October.